The third algorithm is in the referral and transfer one. So this gentleman that we have in our example needs inpatient rehab. And now we have to look to see what is the most appropriate level facility for him. It may be within the region or out of his home region. And this is where each region then needs to look at where they would send patients of this nature to best serve their population. In some communities, there are ambulatory and home-based programs that are available to meet the needs. If this was not available, then they might have to be considered for an inpatient program. And actually in some places, like in the U.S., patients actually travel to the center and they stay in nearby accommodations for a limited period of time to attend the appropriate outpatient programs. So then the patient would hopefully be referred to the appropriate place and undergo their inpatient rehab. And then when they're deemed ready, they would proceed to the community reintegration. If the patient does not make further improvements in inpatient rehab, then there is another path to ensure that the patient is again reassessed to see if they would benefit from this in the future. Just want to point out on this algorithm, there is a little circle A sort of towards the bottom center of the algorithm. This is meant for patients who were really initially screened and deemed not appropriate for rehab services, and then they are to be referred directly to community services for information and support, even though they may ultimately end up in a long-term care placement. So the community reintegration algorithm is the largest one. There are actually 3 entry points into this algorithm. So you can come in either from acute care, inpatient rehab, or from outpatient rehab. And the processes are relatively similar. So in our example, this person would be entering through the inpatient rehab column here on the right. So a referral would be made to the community agencies, and then those agencies can then contact the patient and provide information on their services. If the patient needs case management or some kind of peer mentoring, this is also where that service can then be introduced. Community services would also include recreational and support groups that might be available in the community, as well as involvement of their primary health care providers. So for our patient, we will also look into availability of outpatient rehab services and where they might be delivered to the person in the community, in addition to those community supports. This last slide algorithm is actually the third entry point into community reintegration, and is for those who are coming in directly from an outpatient setting. And it's essentially a similar process where there's contact made with community agencies and information provided to them, and the supports are set up if they're appropriate. All right. We're doing okay for time, Diane? I think we're still all right.
All right, Jennifer, you've got about 2 minutes left, so...
Okay, 2 minutes. I think I can fly through it. So this slide is just to remind people that patients can actually cycle through these algorithms depending on their needs. And each center, again, will have to see where their referrals should go in terms of what centers are available to them and what community services are provided. If there are gaps, the hope is that the region can then be able to recognize that using the best standard tool and to focus their resources on those gaps. In Section 4 of the Service Delivery Framework document, we have selected 18 best practice standards for stroke rehab that spans the continuum all the way from admission to community reintegration. And those standards, how do I go back? There we go. Those standards actually came from actually reviewing a whole bunch of documents from different sources, including the ones that you see here from the Canadian Best Practice Guidelines, the Alberta Strategy, and the Ontario Strategies. And we've selected these 18 to try and keep things on a practical and doable level. And I just want to thank Linda and Diane for doing a lot of hard work in terms of reviewing and summarizing these documents for us and helping us select these 18. So these 18 evidence-based standards are in the guidelines. I wouldn't have time to go through every one of them now, but they are evidence-based. It follows the entire continuum, and it highlights functional issues and access issues for stroke survivors. And it can provide a basis for actual clinical practice evaluation. And we try to, again, maintain a strong focus on the community reintegration piece. We've also included in the appendices of the document a list of stroke service inventory. And this includes TIA clinics, stroke centers, and stroke rehab centers divided into each region. So having an up-to-date inventory should help the health authorities in organizing their referrals and transfer process, just to be aware of what's available where. And we've actually included contact names and emails so that you can get more details about the types of services that are offered. We know that a lot of things are in flux, so this is something that would probably have to be updated and looked at on a regular basis. And in terms of recommended next steps, we are going to need some commitment from the Ministry of Health and the health authorities to establish a stroke system to allow these best practices to take place. And each facility will then need to identify their own role and see where they would like to fit in terms of the continuum, and partner with each other to share resources. It's certainly our hope that this service delivery framework will be endorsed by the Ministry of Health and the Health Authority as a defining document for integration of stroke rehab and reintegration system in the province. And in conclusion, I hope that this document will be a guide to help administrators structure and allocate stroke care resources across the province. And I do believe that evidence-based stroke practice will ultimately lead to better patient outcomes and greater efficiency in the use of rehab resources. So I think my remaining 2 minutes are up. Thank you for your attention, and we're happy to entertain any questions at this point.